Yeah, yeah. Yes, I could do it now. I could record.
Okay, sir.
Your voice is clear.
Yes, sir. Voice is clear.
Shall I wait for like 5 minutes more? 10 minutes, 5 more minutes, maybe. Hello.
Sir, your voice is kind of low, sir. Can you?
Yeah,
Um,
yeah. I think so. It is now. Is it okay?
uh,
No, is
no,
it okay
sir.
now?
It's still low.
Still low.
Yeah, sir.
Not be. Is it okay? No. Is it still low?
It's still low, sir.
But I am speaking to the microphone. Is it okay now? I don't know. Is it like still very less? No, many people are writing the voice
One
is
second.
clear. Yeah, should not be a problem. Yeah, I think I'm getting messages that voice is pretty clear.
Sir, it's clear in the earphones, but it's not very clear in the speakers, sir. That's what I meant.
I don't know. I don't know the reason for that.
I use my earphones, sir.
I think we can start. Yeah, fair enough.
Sir?
We can start. I think so.
Yes, sir.
Right. Okay. So, good evening, students.
Sir, can you wait
Yeah.
like 2 minutes?
Sure. Sure. Sure.
Uh,
Sure. 2 minutes is fine.
okay.
Can you see the screen?
Yes, sir.
Is the voice clear now?
Uh,
It's the same.
can you speak now?
Yeah. Can you hear now? Is it okay?
I can hear you, sir.
Right. I mean, it should be okay. Maybe I'll raise my voice.
Yes.
Okay. Maybe yes, we can start. It's okay. I think so because we'll go into the
Yes, sir.
topic.
We'll start.
We'll be
Yes, sir.
actually going to the topic 5 minutes from now. It's more like
Okay.
introduction only.
Yeah.
I think somebody who can join from this point is also is okay, right? They won't miss much. Right. So, good evening, students from India and from Oman as well. Thank you for attending this session. Okay, so this is part of those monthly sessions that I've planned for students. So this topic today is a very common topic. The topic has been decided as seizures in children. So as it has been usual that I will just start with the one small case and then we'll go into the topic proper. And then I will be actually telling what I wanted to do in this particular session today, right? I will try to keep it as simple as possible without not much of facts and more of practical points, okay? So I'll just start with one case, very common scenario that we usually see in the outpatient practice. So there's a 11-year-old boy with 5 episodes of probable giddiness and loss of consciousness. Okay. The first one was that when the child was standing in the school assembly, he felt uneasy with some blurring of vision and he had an injury, fall with an injury to the forehead. This episode was witnessed by the school friends and teachers, and it was approximately about 5 minutes. And the teacher told that he witnessed the child became stiff and he was a bit jerking. And a little later, he regained sensorium. So 2 months later, he had a similar episode. Okay, so he had a similar episode while he woke up at home. The child does not clearly remember the event, but he feels that becoming a bit dizzy and with sudden loss of consciousness. He was evaluated by a neurologist who said that who did an EEG and it was normal, and he said reassured the family that don't worry. But this child again had similar episodes a month later, like around 3 to 4 episodes more. Similar nature, some giddiness and loss of consciousness. So parents took him for a second opinion, and they did met another neurologist. They did EG there, and it was reported as abnormal. The neurologist told the child is having epilepsy. Let's start him on sodium valproate. He was started on sodium valproate. After 1 month of starting the treatment, despite sodium valproate, he had similar episodes lasting for 2 to 3 minutes. At this point, family took the opinion of a third doctor, and he suggested that we should change the medication. He repeated the investigation, that is EEG. It was normal this time. Okay. So the parents were fully confused. At with one neurologist, the result is abnormal. With another, the result is normal. One neurologist is saying that you should start medication. Once is reassuring that no medication is required. Right. So they were not happy in the current scenario, and they wanted a good solution. Okay. So this is common. So what would you do in such a situation? So would you restart a new anti-epileptic? Would you review the diagnosis? Would you refer to another neurologist? So this is a very practical problem. I'm not asking any Zoom questions or polling. It's just like for your thought of what can happen. So this is the reason that we are having this particular topic today. I hope to clear some of these confusions that can arise in OPD practice of how we should think and how we should approach such a scenario. So the topic for today is let's describe seizures. It's a very simple introduction to seizures. The key word here is what I put in red, describe, DESCRIB. This is a mnemonic. So this full presentation we will do with this mnemonic, okay? So most of these slides are just explanatory. They are not like factual slides. But in some of the slides at the top end, I would have a yellow heading. You know, the slides with the yellow heading are something a bit factual that can be used by students to memorize certain facts. Okay. So why this topic? As I told you, these seizures especially are very common in children. It is a problem of the developing brain. Unlike in adults, I'm sure the adult neurologist, Dr. Banu, would have taken you the topic epileptic seizures and epilepsy for you. I do remember in the group it was shared. But I would be approaching in a different way because I believe that seizures are primarily a pediatric problem because it's an issue of a developing brain, and almost 1 in 20 children can have seizures as a symptom. But if you take it as a disease, 1 in children only would have recurrent seizures, unprovoked seizures, and they would have epilepsy as a disease. So it's 1 in 100 would have epilepsy as a disease, children. And 1 in children, 100 children surprisingly would have some movements which can look like seizure or abnormal movements. And these children are unfortunately misdiagnosed as epilepsy. Okay. So that is the importance of knowing this topic. You don't want to underdiagnose epilepsy and you don't want to overdiagnose epilepsy, right? So you need to have your concepts pretty clear. Okay. So the theme for today is that only basically two major themes. The first theme is that all students here should very clearly know what is a seizure, what is an epileptic seizure, what is a non-epileptic seizure, and what is epilepsy. So all these terms have subtle differences, but you should be very absolutely clear in their meaning. And as I told you in the beginning of the presentation, we will use this mnemonic called describe to give a basic outline of how would you approach a child presenting you with seizures. Okay. So like I usually say, this is just a conceptual topic. This is not a factual or theoretical book-based topic. Okay, it's only basically practical points for understanding. So let's go to the first theme. What is a seizure? What is epileptic seizure? And what is non-epileptic seizure? Okay. So the moment I ask what is a seizure, okay, the picture which comes to your mind for most of the students here is a child who is having uprolling of eyeballs, frothing from the mouth, clenching of the teeth, and violent shaking of the limbs. Okay. This is the picture that comes into your mind. Okay. When I say what is a seizure. And if I ask you what is the definition of seizure, the intelligent one among you will say, would have memorized the definition from Genong and Guyton physiology, would say that seizure is abnormal hypersynchronous neuronal discharge, okay, which causes some electrical disturbances in the brain. But if you leave this physiological definition or pathological definition, if I want to give a clinical definition of what is a seizure, the English word seizure comes from the word seize. Seize means an attack, sudden attack, okay. So it's very simple. A seizure is any sudden event, paroxysmal event. When I mean paroxysmal, there is an on-off phenomena like a switch. I'm oning a switch and I'm switching off, okay. So it's a sudden event which has switch on, switch off phenomena. And this sudden event or paroxysmal event would lead to functional alteration in the human body. Okay, so this is the basic simple definition of a seizure. A seizure is a sudden paroxysmal event which leads to functional alteration. And most importantly, this functional alteration in the body could be anything, absolutely anything. It could be a visual phenomena, it could be auditory phenomena, it could be sensor phenomena, it could be visceral phenomena, motor, sensor, emotional, behavioral, autonomic, or a psychic phenomena. Okay, so this clarity of concept should be there. A seizure is any sudden event which leads to functional alteration in the body. Okay, sudden on and off phenomena. Okay, so based upon this, then you need to clearly know what is an epileptic seizure and what is a non-epileptic seizure. So any sudden event is a seizure, but if that sudden event starts from the cortical gray neurons, if it is because of the unusual activity from the gray matter neurons in your cerebral cortex, okay, cortex, not from white matter, not from basal ganglia, not from cerebellum, then it is called as epileptic seizure. But if that abnormal sudden functional alteration is from the other portions of the brain, like basal ganglia or cerebellum or brainstem, you call it as a non-epileptic seizure. Okay, so epileptic seizure, the source of this sudden event is from cortical gray matter neurons, and for epileptic seizure, the source for the sudden event is the other areas of the brain. So this definition also should be very clear. So what is this video is an example of a very simple event. The child is like a 1.5-year-old boy who cries for toy. Okay, he becomes blue discoloration. He becomes like cries, but suddenly he cannot cry. The sound is not audible. He becomes a little bit apneic, stops the breathing. He becomes a bit stiff and has this sort of arching of the body, and he loses the consciousness. Okay, this is a common event. Okay, that's it. He loses the consciousness only for a brief duration of time. But if you see here, after some time, okay, after some seconds, he regains the sensorium and is like absolutely normal. Even the mother is not at all panicked. She's just rubbing the child. Okay, and the child becomes absolutely normal again and starts playing again. Okay, so would you call this as a seizure? Okay, so what is this event? This event is a breath holding spell, which can you call it as a seizure? The answer is yes, it is a seizure because it is a sudden event. Now, can you call this as an epileptic seizure? The answer is no, you cannot call it as an epileptic seizure because the activity, the so-called sudden breath holding and cyanosis is not from cortical gray matter neurons, but it is basically from the brainstem. Okay, so this is a seizure, but it is not an epileptic seizure, but breath holding spell is a non-epileptic seizure. Okay, so this is why I showed this video in the beginning. So there are so many events which can look like the seizure, but by definition, if those events are only because of neuronal discharge from gray matter neurons, you can call it as a epileptic seizure. Otherwise, they are all non-epileptic seizures. Okay. So this is the definition. Epileptic seizure is a manifestation of epileptic hypersynchronous self-limited activity of the neurons in the brain. And a non-epileptic seizure can look like an epileptic seizure, but it is a consequence of different non-epileptic mechanism. Okay. So there are so many non-epileptic events in the course of the session. I will be just showing some videos of some of the non-epileptic events, which can actually very much look like a seizure, but it is not a seizure. It is important to recognize these events like jitteriness, breath holding spells, shuddering attacks, okay, opsoclonus, spasmus nutans, so on, so that you don't make a wrong diagnosis of epileptic seizures, okay, like syncopal attack, all those things. So you have to be very careful not to overdiagnose epileptic seizures. So this is another example. A child, as you can see, has this rapid, sudden eye movement, okay, which is chaotic and multi-directional, okay, with extreme irritability. Now, if this child comes to the emergency room, it is possible the emergency physician or general physician can think that this is a seizure, okay, because he's having this rapid eye blinking with abnormal multi-directional eye movements. But this eye movements is called opsoclonus, and this is because of the child having neuroblastoma, okay. So this abnormal eye movements is also sometimes wrongly diagnosed as seizures. Another example, just to say that non-epileptic seizures are equally as common as epileptic seizures in children, okay. So then what is epilepsy? So this is very, very important. Now, epilepsy is not a symptom. Epilepsy is a disease. So whenever we say epilepsy, epilepsy is a disease, not one disease, another important problem, another important concept, okay? Asthma is one disease. Diabetes is one disease, but epilepsy is a group of diseases. It's a group. Okay, that's very, very important. Characterized by recurrent unprovoked epileptic seizures. So whenever you have a disease, okay, with the recurrent epileptic seizures, you call it as epilepsy. But now this epilepsy is not one disease. There are many diseases within epilepsy, meaning by there is multiple reasons for a child to have epilepsy. For example, you can have a child who had birth asphyxia and cerebral palsy having epilepsy. That's one particular reason for epilepsy. You can have a child who had a brain tumor having epilepsy. That's a different reason for epilepsy. You can have a child with a genetic disease having an epilepsy. That's another reason for epilepsy. So what are these different groups within the epilepsy? Okay, so you should always think about epilepsies rather than epilepsy. Okay, you should always try searching the cause why this particular child is having a particular epileptic seizure. Okay, and then look for it. Okay, so that is known as epilepsies. Okay, so what could be the reason? So the ILA 2017 brought out a very good classification system, which includes how do you understand seizure types, how do you understand the different epilepsy etiology. So this particular one important cartoon or one important diagram from the recent ILA 2017 classification. I will talk about this, of course, in the presentation. But if you look at the deep right hand side of the presentation, you can see there are 6 major etiologies for epilepsy, or 6 major groups for this epilepsy. Okay, so these the 6 major groups are structural epilepsy, when somebody has a brain tumor or a brain trauma. We have so many causes for genetic epilepsy, like sodium channel epilepsy, potassium channel epilepsies. Okay, like tuberous sclerosis is a genetic epilepsy. You can have infectious epilepsy after HIV, after measles, after tuberculosis. Okay, so you can have a post-infectious epilepsy. You can have epilepsy after metabolic derangements in the body, like hypocalcemia, hypoglycemia, inborn error of metabolism, like mitochondrial disorders. You can have epilepsy after immune disturbances in the body, secondary to autoimmune disorders like lupus, like NMDA receptors, and so and so. Okay, so always think about a group. Okay, that child is having a focal epilepsy. Okay, this child is having generalized epilepsy. Is this generalized epilepsy because of structural cause? Is this generalized epilepsy because of genetic cause? Is this generalized epilepsy because of metabolic cause? So you should always think about the etiology, right? And there is something called epilepsy syndromes. I will talk about this in the presentation. Okay, so at this point it is clear, this is the first part of our theme. So a student should clearly know what is a seizure. A seizure is any sudden event, okay, with the functional alteration of the body. What is an epileptic seizure? Epileptic seizure is because of hypersynchronous neuronal discharge from the cortical gray matter. Okay, and what is a non-epileptic seizure? Are abnormal movements from other part of the brain. And what is epilepsy? Epilepsy is a disease in which there is a tendency to have recurrent epileptic seizure, and epilepsy can be because of multiple other groups of diseases. Okay, so this is your first half, or the first part of the presentation, where you should be absolutely clear. So now let us go to the second part. I will now start using the framework called Describe. This framework was used by the UK people, NICE guidelines, where they wanted the GP, the general physicians, to rightly diagnose epilepsy and do a right referral to the neurologist. So this is not my acronym. This is a standard acronym, okay, but gives a very good idea about how would you approach a child with epileptic seizure. So what is this Describe acronym? Okay, it's very simple. I teach wherever possible to all of them. It's very simple and very easy to remember. So the first D in Describe is you need to describe the event. This is about history taking, okay? You need to have a good history taking where you describe how the event started, how the event progressed, and how the event ended. And after the description of the event, E is that you would say whether it is an epileptic seizure or a non-epileptic seizure. Okay, so a reasonable conclusion can be made after you describe the event as epileptic seizure or non-epileptic seizure. And then S is the seizure type. Okay, so you have to comment about the seizure type once you take a good history. This child is having generalized seizure. This child is having a focal seizure. Okay, so this is the seizure type. And then you should comment whether the child is having an epilepsy syndrome, yes or no. So what is an epilepsy syndrome? I will tell you very soon. Okay. So, and C is what is the cause for epilepsy. So there are 6 major etiologies for epilepsy: structural, genetic, metabolic, immune, infection, and unknown etiology. And always ask for RIBE, that is relevant impairment in behavior and education. Okay. So this is how we are going to start the presentation today. So what are the important points you need to take in the history? So this I will be describing very soon, okay? And then we will say, how will you say about whether it's an epileptic seizure or non-epileptic seizure, okay? What are the clues for non-epileptic seizure? And then we will briefly discuss about different seizure types, generalized seizure types and focal seizure types with the help of videos, okay? Then we'll briefly discuss about the etiologies of epilepsy, right? So this is how we are going to do. And wherever I'm using a yellow color title for the slide, those are important slides, okay? So describe the event. How would you describe the event? Okay. So there's a huge difference between how a neurologist describe the events and how a basic medical student describe the events, or how an emergency physician describe the events. But many of the times the students just say this child is having uprolling of eyeballs and tonic clonic jerking of the limbs. That's it. There is no description of what happened before, how the event progressed in a sequence, first step, second step, third step, and how the event ended. What was the scenario? Was the child playing, sleeping? Nothing. Okay, the emergency physician or multiple times whenever we discuss with the juniors, they just say the child had uprolling of eyeballs. That's it. So you need to have good description of event. I will give you some clues of how you can do that in a nice way, right? So you have to have, first of all, a good ears, okay? And you need to have a good eyes, okay? It's almost like Sherlock Holmes, like a good crime scene. You need to go inquire a lot, okay? You need to listen to the child, you need to listen to the mother, okay? And sometimes, of course, we need a mobile video recordings, okay? And sometimes we need the help of investigations, okay? Right, but what is the we should do it in a right way. If you do it in a right way, in the end you will have a good hypothesis about what is the nature of the event, whether it is epileptic or non-epileptic, generalized or focal, which part of the brain it is coming from. You can localize if you take a good history, right? And you can also be able to comment about why there is an epileptic seizure, okay, about the etiology. Okay, so to do it in a very nice way, you should take a good history. You should know what to ask. I should ask this. I should ask this question, this question. Okay, that comes from some understanding of the theory of seizures. And students should also have about basic classification of seizures, generalized seizures and focal seizures. What is atonic seizure, tonic seizure, and so and so. So if you have a basic idea of the seizure, you can even actually act and show the parents. Did the child do like this? Did like this? Okay, that comes with experience of showing, demonstrating the mother and father of how a seizure can look like, okay? So in the history should always start like a crime scene. Just think that you are a police officer, okay, or somebody who's come at a crime scene. You don't want it to jump into the scene. You want to know how the scene started. 9 o'clock in the morning, the child was talking with his friend. He was watching TV. At that point, he suddenly looked at the right side, okay? So it should start like a crime scene, okay? You should ask about all those behavioral events and non-motor events, okay, before asking about motor events. This is very, very important. Did he have a sudden fear? Okay. Did he feel sweating? Okay. Did he feel the cold extremities? Okay. Did he feel some unusual sensation in the stomach? Okay. Did he feel some unusual sensation in his eyes? Okay. And then he started having this stiff limbs. Always inquire about non-motor events. Try asking the child. You will be surprised. Children more than 6 years sometimes are very intelligent. They'll be able to tell, or some children will be able to draw and show what happened to them, right? And try to getting the information from the observer people who show and from the other doctors as well. Mobile video recording these days is the biggest boon. Okay, it's very useful. Okay, any little doubt, ask the parents to make as much as videos as possible. Talk these videos, take to your colleagues, discuss with them. Okay, it makes the diagnosis much more right way. So after inquiring the history, the student should conclude whether the seizure was epileptic seizure, non-epileptic seizure. He should try to classify into two major types of generalized seizure, okay? And he should try to think anatomically, right? This comes with experience, of course, but you can try to think anatomically from which area of the brain this particular seizure is coming from, okay? So usually any event, sudden event, okay, even if it is not an epileptic seizure, okay, any sudden event would always have three phases. What happened just before the event, called as a pre-ictal phase, what happened during the event, and what happened after the event. So always split your history into these three parts. So you will be in a very nice very nice sequence. So your history will always look very sequential and chronological in a good sequence, okay? So a pre-ictal phase is also called as a prodrome phase. Usually it is characterized by non-motor behavior. Usually the triggering factors are seen in the prodromal phase, like it could be even a hot water bath, you know. Some children have seizures after hot water bath. That's a trigger. Some children would have seizures after watching the sun. Some children have seizures after watching mobile phones, light, okay? Interestingly, some children can have seizures after seeing a specific color patterns, okay, color dress. So there are so many triggering factors, okay? Ask about these triggering factors. Ask about prodromal symptoms. Did the child have URTI? Did the child have fever? Did the child have headache? And so and so, okay? Is there any change in behavior 1 to 2 days preceding the seizure, right? Then when you talk about the ictal events, usually there is a progression, okay? The good observant parents may note the progression, but of course most of the parents are scared. They may not note the progression, but still, if you're able to get a sequence and an idea, okay, this first step, the child always, I put 1 2 3 in front of the parents in a paper, and I say what happened first, and then what happened, and then what happened, okay? So then the parents may be able to give some good idea, right? And post-ictal event is that what happened at the end of the seizure. How did it end? Did the child immediately become better or took time to end? So these can also give you clues, okay? So the preictal phase is the scene, okay? Again, I'm repeating, is whether the child happened in sleep or awake. This is very, very important because so many benign seizures happen during sleep, okay? Very important question. In fact, this is one of the questions I asked at the starting itself. Did it happen in sleep or when the child was awake, okay? So once you know it's sleep, it's only 2 or 3 types of seizure happens in the sleep. Very easily you can reach the diagnosis. Triggering factors and the non-motor behavioral events. And in the ictal phase, again, these are the yellow slides. So try to remember whether there were motor events or whether they were non-motor events. We will discuss more about motor events and non-motor events. Okay. The mother and father can use different terms, but you should be able to characterize those events. You should ask more like inquisitive, more like targeted history. What do you mean by stiffening? Did the neck turn to the right side, to the left side? Okay. Was there a twisting posture? Was there a flowing posture? Was it a jerky movement? Okay. You should try to ask more and more about how it looks like. Okay. Some of them will be able to explain if you are asking leading questions of how an event looks like. Okay. Right. So then these are some of the terms that we can ask, and these are the meaning of those terms. So if you ask about stiff extension and stiff flexion, it means tonic seizure. If you ask about arrhythmic jerk, a jerk which is coming like an electrical shock, okay, here and there, it means a myoclonic seizures. If you see a rhythmic violent jerks, it usually means a clonic seizures. If you see the eyelid alone jerks, it means an eyelid myoclonia, okay. If you see a child becoming limp and flaccid and suddenly losing a tone, it actually means a atonic seizure. If you see a child who's thrashing and pedaling and kicking, okay, it could mean a hyperkinetic type of a seizure, okay. And if you see a sudden episodes of trunk flexion, it could mean a spasm. So use these words to understand how are these motor events, okay. So these are the descriptors by the patients which you need to ask. There are so many non-motor events, okay. It could be a behavior, emotion, fear, okay, or sudden automatic behavior. Like I had a child, interesting child, a teenager, 14-year-old boy, okay. Every time before the seizure, he would take his comb, okay, and will start combing his hair, okay, as if he's, looking in front of a mirror and combing the hair, and then he would have a seizure. So this sort of a semi-purposeful behavior is known as automatism or an automatic behavior, okay. So this can give a clue where the seizure is starting from. Any sudden emotion before the seizure, like fear, okay. Or I had a child who used to suddenly go cry and go and hug the mother. That was an insular seizure. She had an intense fear. So intense fear starts from the insular area of the brain. So she had a tumor in the insula of the brain. Okay, any sudden emotion which precedes the seizure. Sudden sweating which precedes the seizure could be parietal lobe seizure or autonomic seizure. Okay, so some seizures from the parietal lobe can have sensory symptoms like an insect crawling on the hand. Okay, so that can give a clue that it is a parietal lobe seizure. Any suddenly language problem or thinking problem can indicate it is a frontal lobe seizure or a cognitive seizure. Okay, see these terms I'm putting here for you to make understand that seizure is so big. In fact, your brain controls everything, isn't it? So seizure can produce any symptom. To be very honest, even seizure can produce vomiting. Seizures can produce diarrhea. Okay, seizure can absolutely produce any symptom in the human body. Okay, so you should try to ask all these clues, but try to ask smell change, vision change, vertiginous sensation before a seizure, and so and so. Okay. Right. So in the post-ictal phase, if the seizure, so there are certain non-epileptic events, even though they look very dramatic and bizarre, the post-ictal event is not so dramatic. The child would behave as if nothing has happened. Okay. So if you have a post-ictal phase where the child behaves as if nothing has happened, it could be a non-epileptic seizure. sometimes even a psychiatric event called as a psychogenic non-epileptic event. Okay, so the way a seizure ends, if it's a true epileptic seizure and if it was prolonged, the child would at least have some confusion and loss of consciousness for a period of time. Okay, so there are certain seizures which starts from the temporal lobe, which usually have long prolonged postictal phase. Like you can have a child having seizure only for 30 seconds. Okay, like just brief eye blinks and chewing movements, but they have like a sleep, they sleep for like 2 to 3 hours after this small eye blinks. So immediately it gives a clue that this particular seizure is from the temporal lobe. So if your seizure is only for like 10-15 seconds and your postictal phase is like for 2 hours and three hours, always think about a temporal lobe seizure. Okay, similarly, a seizure can look very bad in a frontal lobe, thrashing, pedaling, the child can cry and jump, but once the seizure ends, the child would behave as if nothing has happened. That's a very quick recovery to the normal, and this is one of the feature of a frontal lobe seizure. So these are some of the clues that you can get in the post-ictal phase. Okay, so I've told all these things that always go in a 3-step: pre-ictal, ictal, and post-ictal. Even after said that, these children, it's very difficult sometimes to take history. I agree, from children, especially because parents would be confused. They don't know how to explain the events. Okay, children may be confused. They may not remember what exactly happened to them, but it is always an attempt. You should keep trying to elicit a good history. Okay, some of the clues as what I've discussed all in the last few slides. Okay, you can use open statement. I'll tell you what you mean by open statements. Okay, like not putting leading questions in the beginning and slowly asking the child what happened, and so and so. Always go in a sequence. Always ask about non-motor phenomena. Be inquisitive. Try to spend some more time. Don't jump into a conclusion very soon. Okay, this was very, very useful in so many cases with me. Okay, if you jump into a conclusion, it may not even be an epileptic seizure. Okay, it may be a non-epileptic seizure. Okay, try to get a lot of videos. Okay, reviewing videos with your own colleagues, other neurologists, other doctors is very helpful. Okay, some of these children can draw beautiful pictures and show what they feel. Okay, so don't assume it's an epileptic seizure before you reasonably rule out a non-epileptic seizure. This is a very golden rule. Don't assume it's an epileptic seizure. Always think, okay, why this is not a non-epileptic seizure? Why this is not a chorea? Why this is not a dystonia? And only if you're reasonably sure it's not a non-epileptic seizure, you can take it, oh yes, it is probably an epileptic seizure. Okay. So some way of asking open questions, like this child has an occipital seizure. Okay. The mother says that the child cannot see. So you ask the child, can you not see? The child says, I cannot see. Then you ask the child, what do you mean you cannot see? The child says, oh, well, I can see, but there were some things there. Okay. Then you ask the child, what do you mean by some sort of things? The child says there were red things, there were green things, and there were blue things. You go probe further. Okay, what do you mean by red things? What do you mean by blue things? Is it like a flower? Is it like a square? Is it like a blob? So from open question, you are leading to a leading question. So if you use these techniques, you'll be able to reach to some form of conclusion. Okay, like this child had an occipital seizure, and you can see how beautiful they feel. If you ask the children to draw, these are the occipital aura the children had seen, the patterns of, squares, circular blobs, scintillating like pictures. Okay, these are sort of images the child can actually visualize before a proper seizure. So if you know that there is an occipital aura, you are 100% sure that there is a occipital epilepsy likely. Okay, so this is just a video just to show about how a detailed history is taken. Okay, it's a
Well, I would have liked to have seen Sarah actually and heard from her, but I think let's see how far we can get without perhaps bringing her along next time. Okay. So the GP's asked me to see Sarah because she's been having some attacks. Is that correct?
That's right. She's been having them for about 6 months now.
And she's how old now?
She's 2.
Okay, well, why don't you tell me about the attacks?
Well, the first one happened, it was back about 6 months ago, as I said. And she was playing with her older sister. And suddenly, I suddenly heard her cry out, and I turned round, and she was on the floor and blue, and not breathing.
And so that was the first time. And that was how old she then? What did you have?
That's about 18 months. She's 2 now.
She's 2 now. So
Yes.
she was about 18 months then.
Yes.
And how many has she had since then?
She's had, I suppose, about 4 or 5. Yeah, 4 actually. She's had 4.
And when was the last one? Perhaps you could just tell me, have they all been essentially the same or different?
They've been mostly the same. They've been a bit differing in length. And also they've all been when she's either been playing with her sister with the toys or when I've left her, actually.
So have you witnessed any of it that's all the way through?
One of them. One of them.
Okay, and was that, do you think that was a fairly different attack?
I think so, because the end looks exactly the same.
Perhaps you could take me through that attack then.
Well, she was playing with her sister, and they were playing with, I can't remember what they were playing with. I think they were playing with the animals of the Noah's Ark. And her older sister wanted one that Sarah had, and she took it off her, and Sarah just got cross. She cried out. She went a really horrible blue colour, and she fell to the ground quite. I think she might have hurt herself again. And she was stiff. And then when I went to her, she took a big breath in, and then she started breathing and whimpering a little bit.
Okay, so that attack, was she well before the start of that attack?
Absolutely. Ordinary day, yes, it was.
What time of day was it?
No, it was about 3:30. Her sister had come home from nursery, and they just started playing together.
Is his sister taking a toy with her?
That's absolutely, yes.
And she started to cry?
Yes.
Was that an ordinary cry?
It was like it was a scream, really.
So she let out a scream?
Yes.
And then how quickly after that did it progress into the attack? I'll count down these seconds. 1, 2, 3, 4, 5.
About that length of time. Yes.
After she started to cry,
Yes.
then the attack.
Yes.
So she started to cry, and then about 6 seconds.
Well, she goes a horrible colour.
Right. Okay. So this video goes on and on and on and on about just taking a history from a child who had a breath holding spell. The idea of showing this video is that you can see how the doctor starts, how much episodes did you see, how much attacks the child had, can you remember the last attack? Okay, can you just take me through to the last attack? How did it start? How long did she have the attack? Okay, I'm sure none of us get trained in this way. We are always in a hurry as far as history taking is concerned. But this is just an idea about that. You should spend a lot of time trying to understand the sequence of what happened and try to help the mother or the father in giving a good sequence of the history, right? So this is the summary of what I told. You always start with the preictal phase, ictal phase, and the post-ictal phase. Okay, you should describe as if the event happened in front of your eyes. Okay, should try to put a sequence about both motor and non-motor events. Okay, you should analyze the events, look like generalized events or focal onset events. Okay, and you should try to analyze whether it is epileptic or not epileptic. And also in the history, you should try to look at the background medical status and family history. Okay, so with this D, we'll go to the next part, E. So till this point, I have explained the history taking in seizures. Okay, so it should be detailed. I'm sure that you would have understood how detailed it should be, focusing on 3 parts: the ictal phase, the preictal phase, and the post-ictal phase. Now, the second part is that after the history taking, you should form a conclusion whether it's a epileptic seizure or a non-epileptic seizure. So right in the start of my presentation, I told you that non-epileptic seizures are also equally common in children, just like your epileptic seizures. Okay. So from this understanding, it is possible to differentiate once you know why it is important is that because up to 3 out of 10 children, okay, are actually misdiagnosed as having epileptic seizures despite having non-epileptic seizures. So I'll quickly run you through an example which I had seen like 4 years ago. It's a very interesting case. This was a 6-year-old boy who had seizures, okay, from the neonatal period. And he had increasing frequency of seizures with multiple vomiting during the attacks and constipation from early infancy. Okay. Now this child was managed with 5 anti-epileptics. As you can see the background, he had some respiratory distress at birth. He had seizures from day 2 of the life. Okay. He was on multiple medications right from the starting. He had a developmental delay. Though the MRI brain and EEG reports done multiple times was normal, and he was on 5 anti-epileptics. So this child came for evaluation of intractable epilepsy. Okay. So I proceeded with taking further history. When I asked the child what the child had, the mother told the child had increasing events for the 6 months, almost 20 to 30 episodes. Okay. Each episode lasts for 2 to 5 months. which starts as like tonic stiffening and extension of the trunk with bluish discoloration of the lips. The child would have difficulty in breathing during the stiffening episodes, would have increased salivation and vomiting, and would have some vacant, but there will be no vacant stare, no jerk-like contractions or no neck turning, okay? But every episode would have this increased salivation and vomiting, and every episode would have this bluish discoloration, okay? Interestingly, this child also had severe constipation from infancy, okay? There was no family history, and the rest of the history was not contributory, okay? With this history, the examination absolutely was not contributory. The child had a normal examination, except that he had some gingival hyperplasia because of chronic phenytoin drug therapy. He had a normal examination for a child, but he had a global developmental delay. Okay. Now I did the investigations. I did MRI brain from my hospital. It was normal. I did video EGs was normal. I did a cardiac evaluation. It was normal. I did a lactate evaluation. It was normal. Everything was normal. So I was not able to understand what was this event until I witnessed the event myself. So once the event happened in front of my eyes, okay, the child was happy that before the event was just looking at the mother, and the child started crying, okay, lots of crying, okay. After the crying, the child started lifting the leg, okay, lifting the leg, became totally red and started sweating a lot. Now at this point, can you think what this episodes could be? This was a very interesting case. Of course, it's a very rare case. And this child was referred as like intractable epilepsy with 5 anti-epileptics. Okay. Now this was this episode. This child was crying. Okay. Become red. He used to keep his legs like this, extended top. Okay. As if he is like literally so much of cry. And then he started vomiting and it's lot of salivation. And after that, interestingly, the child started smiling. Once that event got over, the child started at the mother and smiling as if he was like, had a big relief. Now, this was very interesting. I'm seeing a child who's like crying and arching and getting red and extending the legs. And after the event, instead of like going into a deep sleep, the child is looking at the mother and smiling as if he's at relief. I'm relieved now. I'm so happy now. Okay. So one interesting thing also I saw was that is half of the body during the time got red. I don't think so you are able to see in this image properly, but this half was like pale white in color and the other half was like red in color. Okay. So this is called as Harlequin sign. Harlequin sign is a sign of autonomic dysfunction. So this child had palpitation, this child had salivation, this child had vomiting, and this child had Harlequin sign, which is a sign of autonomic dysfunction. And this child was lifting the leg like this, okay, lifting the leg like this. So all these things made me think, okay, maybe, and with chronic constipation. So I had to search for a lot of literature, constipation with lifting the leg. I was thinking why you should lift the leg. I thought maybe it's just because of pain. Okay, then we thought, okay, maybe this constipation is causing him so much of pain that he's lifting the leg, okay, upwards. So that was the reason for this. So when I put like a chronic constipation with severe pain with autonomic manifestation, I got the diagnosis, okay. It was like eureka moment, okay. Okay, just see what happened. This child at this event, lifting the leg upwards, facial grimacing, reddish discoloration, sweating, smile and facial expression after the event. But when I put in Google, chronic constipation with pain, okay, with autonomic dysfunction, okay, it appeared that the child had in painful crisis. I got the diagnosis. It was written as paroxysmal extreme pain disorder or proctalgia fugax. So all these years, for the last 5 to 6 years, the child was managed with 5 anti-epileptics for a pain disorder. We did a genetic test. It came as positive. So this child had a sodium channel 9 mutation, which is called as paroxysmal extreme pain disorder. And he responded beautifully to gabapentin and lacosamide as painkiller medications. So this case is a very important case. I always mention about this case to make understand that despite 6 years of management as an epilepsy and management as 5 years as with anti-epileptic, this child did not have epilepsy. This child actually had a non-epileptic disorder. So non-epileptic disorders are very, very important in pediatrics, has to be very careful. Okay. So this is important because you need to avoid overdiagnosis and you should avoid misdiagnosis as well. Okay. So non-epileptic events are non-cortical origin. They can be stereotypical. They can be bizarre. Some of them are very permanent and some of them are very, very difficult to treat. Okay. Sometimes it is easier to treat epileptic seizures and very, very difficult to treat non-epileptic events. Okay. So there are different classification systems, but in pediatrics, we remember them based upon their age. So if there is a non-epileptic attack in a newborn, these are the events like a jitteriness. Okay. Okay. There is a non-epileptic event in an infant or a toddler. Okay. It is a breath holding spell. There is a non-epileptic attack in a teenager. Yes, it is a syncope. So it is usually classified by their age of onset as well. Okay. So these are some of the classification systems of non-epileptic disorder. You can divide it as sleep disorders, movement disorders, channelopathies, and so on. I'm not going to the detail. I'm just giving you an idea. And these are the list of the diseases like jitteriness, breath holding spells, syncope, and so on, opsoclonus, and so on. Okay. The idea here is that a student should understand that every student should try to understand and recognize non-epileptic events as well. In fact, this alone is another presentation, but it's just an introduction to non-epileptic events. Let us see some non-epileptic events. So let us see an epileptic event and a non-epileptic event which can look like this. So epileptic versus non-epileptic events. So we have a generalized tonic-clonic seizures. Okay, what are the non-epileptic events which can look like a GTCS or a generalized tonic-clonic seizures? Okay, can you think about it? Okay, so some of the non-epileptic events which can look like GTCS is jitteriness, okay, breath holding spells, a convulsive syncope, and sometimes chorioathetosis. Okay, so some of them which can look like GTCS is jitteriness, is breath holding attacks, infantile tremor syndrome, and chorioathetosis. These are some of the example of non-epileptic attacks which can look like a GTCS. Okay, this can look like a GTCS. Now this child is having a true epileptic seizure. You can see there is twitching around the corners of the mouth. Okay, this is a oromotor seizure. Okay, oromotor seizures which is getting generalized. Okay, and rhythmic jerking of the limbs. So it's a clonic seizure. So this is a GTCS example. And let us look some seizures which looks like a GTCS. So this is an example of a convulsive syncope. This is not a GTCS, but this is a non-epileptic seizures. I'll just go back and play back the video again. This young athlete is being subjected to a Valsalva maneuver. Okay, so after a Valsalva maneuver, there is a brief syncope, and this brief syncope is followed by this shivering like movement. Okay, this is called as multifocal myoclonic. The jerks are more arrhythmic. Okay, it's almost arrhythmic jerks, not rhythmic jerks, like shivering like jerks. And this is an example of a convulsive syncope. This can look dramatic. Okay, convulsive syncope with multifocal myoclonics. Okay, and this is a non-epileptic event because of autonomic dysfunction, and it is not to be treated as an epileptic seizure. Now this child interestingly was on 3 anti-epileptics. Okay, every time she will close her eyes and she will fall down, I'm using a tuning fork and I'm saying this child, you will throw a seizure. So once I suggest a child that you will have a seizure, the child is jerking violently. You can see it's violently. Okay, so I am guiding the child. Okay, now you will have a seizure. The child is doing a seizure. It's almost like a Baba effect. Okay, like hypnotism. Okay, this extreme suggestibility is seen in children with psychiatric disorders or hysteria or conversion, and these events are called as psychogenic non-epileptic seizures. Okay, like bizarre thrashing around. See, you can see the child's eye is closed. In a true seizure, the eyes would never be closed. Eyes would be open and you'd be having a pupillary dilatation. You can see in this video, she's also putting the frothing from the mouth. I told you will have frothing from the mouth, and she's doing frothing from a mouth. Okay, so this is a interesting study we did about non-epileptic seizures. So they are very common in children. Okay, not to be confused with GTCS. This child was on multiple anti-epileptics. Okay, all the anti-epileptics were stopped and she was sent for a psychology, counseling, and referral. Okay. So they can have bizarre pelvic thrusting, eye closure, falls like events are much more common than non-motor events. Okay. Right. So this is a small child having brief jerky shivering like movements while sleeping. You can see that the small baby is sleeping. So even though this is like looking very bad, shivering like movements, this shivering is more like arrhythmic shivering. So this is an example of a sleep myoclonus, okay, and a jitteriness in a, this is an example of a sleep myoclonus in a newborn. So the features of sleep myoclonus are, they are erratic jerks of lower limbs and upper limbs. Okay, the jerk usually happens in the sleep state, never happens over the face. Okay, it never happens over the face. It can look sometimes violent also, but these are non-epileptic events called benign nocturnal myoclonus of the newborn. These are not seizures, or these are not epileptic seizures, I'm sorry. And they usually disappear by 2 to 3 months of age. Now, this is a child who's having this, you can see this shiveriness, okay, or extreme shiveriness or tremor-like movements, okay. This can also looks like a GTCS, but it's not a GTCS. It's more of an exaggerated tremor. And when you hold the limb, it stops. So this is an example of jitteriness, okay, jitteriness in a hypocalcemic or a hypoglycemic newborn. So jitteriness is a form of a shivering tremulousness. This can be stimulus sensitive. With stimulus or with the reflex or sound, it increases and you can stop. And there is no autonomic phenomena with a jitteriness. There is no tachycardia or bradycardia or no sweating with a jitteriness. Okay. And this is another form of a tremor. This child is crying like a goat and is having extreme irritability, anemia, and generalized tremors. This can be misdiagnosed as a GTCS, but this is a infantile tremor syndrome. The child is conscious but is having this continuous continuous jerking movements where the child is fully conscious, and coarse tremulousness. So this is an example of infantile tremor syndrome due to megaloblastic anemia. They can have a trunk tremor, a goat-like cry, and a wing beating like a tremor. Okay, seen in malnourished children. These are examples of choreoathetosis and other types of gratification movements. So these, so it is important to identify non-epileptic events. Most of them are movement disorders like chorea, dystonia, but some of them are developmental disorders. They happen at a particular age and then disappear with life. Some of them are psychogenic events, like I showed you a psychogenic non-epileptic event, and I showed you a post-syncope followed by these myoclonic seizure-like attacks, but they are called as convulsive syncope. Again, they are not true epileptic seizures. Okay, so non-epileptic events can have a pattern. They will not bother the child. They can be bizarre, like tics and all. Okay, tics and stereotypies. Okay, right? And there is no autonomic nervous system involvement in the case of a non-epileptic illness. There is no tachycardia, there is no pupillary dilatation, there is no frothing, there is no salivation, there is no urinary incontinence or tongue biting. Okay. So next we'll go to the seizure types. So having understand how a epileptic seizure looks like and how a non-epileptic seizure looks like, very quickly we'll see the seizure types. So all of you, I'm sure, definitely would be aware about generalized seizures and focal seizures. Okay, so there are two types of seizures: generalized onset seizures and focal onset seizures. Okay, note the word onset. Okay, it is not generalized seizures, it's generalized onset seizures and focal onset seizures. Okay, so again, a generalized seizures, as per as the recent classification from 2017, you should always say whether it is a generalized motor seizure or a generalized non-motor seizure. So every seizure is classified into a motor seizure or a non-motor seizure. Again, a focal seizure, whether it is a focal motor seizure or a focal non-motor seizure. Okay, so generalized onset seizure means it starts from one area, but it quickly spreads into both the sides of the brain. So it's from the bilateral engaging cortical networks. But whereas if it's a focal onset seizure, it is only from one area of the brain. It can later on spread to the other area, but the onset is from only one area. It's localized to one network of the brain. Whereas a generalized seizure has a bilateral engaging networks. It's very rapid in spreading to the both the parts of the brain. Okay. So accordingly, both focal onset seizures and generalized onset seizures are then divided into motor seizures or non-motor seizures. This is very, very important. Motor seizures or non-motor seizures. Also important is that focal seizures is also classified into aware seizures or impaired aware seizures. Okay. So 3 years before, we used to call them as simple partial seizures and complex partial seizures. The new term for them is that focal aware seizures. So a simple partial seizure in which there is no loss of a consciousness arising from one area of the brain is now called as focal aware seizures. Okay. A complex partial seizures where there is a loss of awareness, the child gets confused. Okay. The child will behave like delirious, as if the child is totally confused, is called as complex partial seizure, or the recent name or the latest name for them is focal seizures with impaired awareness. Okay. So this is the latest classification. Okay. So quickly will go through what are motor seizures and what are non-motor seizures. So what are generalized motor seizures? Generalized motor seizures are tonic seizures, atonic seizures, myoclonic seizures, clonic seizures, tonic-clonic seizures, myoclonic, atonic seizures, and spasm. So there are 7 types of motor seizures, generalized motor seizures. But whatever I put in yellow highlight is to be remembered. Okay, this is very important. So somebody asks you what are the type of generalized motor seizures? They are tonic. Tonic means stiffening attack. Atonic means loss or limp. Okay, flaccid attack. Myoclonic means sudden arrhythmic jerk attack. Clonic means violent rhythmic jerk attack. Myoclonic atonic means combination of sudden arrhythmic jerk followed by loss of tone. Tonic-clonic seizures is stiffening followed by jerking of the limbs. Okay, and a spasm means sudden extension or flexion at the trunk and the limbs. Okay, so what are generalized non-motor seizures? There are 3 types of generalized non-motor seizures. There are absence seizures, atypical absence seizures, and combination of myoclonus with absence known as myoclonic absences. Okay, so these are the 3 types of non-motor seizures: absence seizures, atypical absence seizures, and myoclonic seizures. Okay, absence means sudden brief staring episodes. Atypical absence is more prolonged staring episodes, and myoclonic absence is a combination of eyelid jerks with staring episodes. Okay, we'll see those with videos. Okay, what are focal onset motor seizures? Again, focal onset motor seizures can be tonic, can be clonic, can be atonic, can be myoclonic, and spasm. This is very, very important to understand. Okay, so you can have tonic stiffening of only one limb. So that is called as a focal tonic seizure. You can have clonic jerking of only one limb. That is called as a focal clonic seizure. You can have loss of tone in only one side of the body. That is called as a focal atonic seizure. You can have sudden jerk only from one limb. It is called as a focal myoclonic seizure. And you can have a sudden spasm or extension and flexion movement from only one side. They are called as focal spasm. And you can have violent neck turning towards one side. They are called as focal adversive seizures. Okay. So these are the 6 types of focal motor seizures. I will show you with videos. Don't worry. As of now, just follow me and just see how these terms are given. So what are focal non-motor seizures? As I put in the red in the last slide, there are very important A's as far as A, the letter A. So there are 5 A's for a focal seizure. One A is aversion, okay, which is a focal motor event. And if you have the other 4 A's, it is very easy. You are 100% sure it is a focal onset seizure. So the important A's of a focal seizure are aura, automatism, autonomic events, and arrest or a behavioral arrest. Okay. So what is an aura? It is a sudden unusual feeling. Automatism are automatic behaviors. Autonomic manifestations are tachycardia, palpitation, and so on. Arrest is prolonged staring episodes. Okay. A focal seizure, if it starts from the parietal lobe, you can have sensory features. A focal seizure, if it starts from the frontal lobe, you can have cognitive features like fear, emotion, okay, anger, and so on. A focal seizure, if it starts from temporal lobe and so, you can have emotions. Okay. So these are the focal onset non-motor seizures, right? So this is an example of a tonic seizure. You can see the sudden stiffening attack. You can see the sudden stiffening attack. Okay, so sudden stiffening of bilateral limbs. Okay, so this is a sudden generalized tonic seizure. This is a sudden generalized tonic seizure. Okay, right? Can be seen in syndrome. Can be seen in very bad intractable epilepsies. Right. I'll just take a 1 minute break. Just excuse me for that. I'm getting a call from the emergency, and then I'll get back to you. Okay, sorry for that.
Okay, sir.
Yeah,
Okay,
just 1 minute break. Okay, I'm on
Yes, sir,
call.
sure.
I'm on call as well, so I have to take the call. Right.
Okay.
Hello. I'm Dr. Farhan. Yes, Dr. Farhan. I'm fine. Right. Okay. Can I start again?
Yes,
Hello?
sir.
Yes, sir.
Right. Okay. So yeah, so these are the seizure attacks. So there's an atonic seizure. As you know, there's a sudden loss of tone. I don't know whether you saw this. So this is a sudden drop attacks or sudden limpness. Okay. And you can see this child who's having sudden arrhythmic jerks, see, sudden rapid jerks, shock-like jerks, and these are classical examples of myoclonic seizures. What is the difference between clonic seizures? Clonic is more rhythmic jerks, than these are arrhythmic and sudden shock-like jerks. Okay, so these are myoclonic seizures. Okay, and these are very classical absence where there is blinking and staring episodes for around 5 to 10 seconds. Okay, you see the child, I'm giving a piece of paper and I'm asking the child to blow the paper, do the hyperventilation test. And as you can see, the child is doing hyperventilation, would have this transient, you see, eye blinks, and the child gets, brief vacant stares. And after that, when I call her name, she becomes normal again. So these sort of transient staring attacks or transient brief staring for 5 to 10 seconds are known as absences. One easy way to do is that give a piece of paper and ask them to blow it. So you can easily elicit absence seizures. So this is very important in pediatrics, not to miss an infantile spasm or epileptic spasm. So as you can see here, the child would have this sudden flexion. Okay, note here now. Yes, this sudden sort of flexion in happening multiple episodes in a day, the child would be bothered by it. Okay, parents may not realize why the child is bothered, but this will be sudden shock-like flexion of the trunk, or it's called as salam attacks, sudden flexion or extension. These are called as infantile spasms. Okay. So this child is a very interesting child. He's showing a focal impaired seizure or complex partial seizure. Okay. So you can see all type of movements. You can see automatisms. You can see admersion. Okay. Now here, note here, this is a very good, nice video from YouTube. See, this sort of staring or neck turning is called as adversion. Okay. And then he's like trying to fall only onto the left side. It's like a focal fall. And here he would have a sudden hyperkinetic movement like this. Okay. Some funny behaviors like rubbing the hands, wringing the hands, automatisms, and he's like going around in a circles, which are automatisms. Okay, walking in a circles. Okay, walking in a circles, suddenly staring, looking at one side. Okay, you see, looking at the right side and staring for long time, some chewing. So this, he's having automatisms, lot of automatisms, circling automatisms, hand wringing automatisms. He's having a behavioral arrest. So the 4 A's of focal seizure are aura, automatism, and arrest. So this is a very interesting video about showing a complex partial seizure. Okay, and the child is absolutely not aware of what is happening to him. So this is a very important slide. So after showing you the videos, all of you should be very clear of what is a tonic seizure, clonic seizure, tonic-clonic, myoclonic, atonic, absence, atypical absence, aura, automatism, arrest, and adversion. Aura is an unusual feeling, sensation, visceral phenomenon. Automatism are automatic behaviors, non-purposeful, stereotypic behaviors. Arrest is prolonged staring, okay? And adversion is forceful neck turning, okay? So if you are getting these 4 A's, you are almost 100% sure that it is a focal seizure. So if you ask about history of these 4 A's, okay? Right, so next is, once you have understood till this part, okay, then you should know whether the child is having an epilepsy syndrome, yes or no. So what is a syndrome? Like you have a Down syndrome. You say Down syndrome and there is brachycephaly, when there is a Sandel gap, when there is a simian crease. Likewise, you can say it's an epilepsy syndrome when you have a typical combination of features, okay? And this combination of features, you can easily avoid over-diagnosis and over-investigations. So if you know it's a very classical childhood absence epilepsy syndrome, you don't have to do MRI, okay? Because you know it's an absence epilepsy syndrome. It has a very characteristic feature. So what do you mean by this epilepsy syndrome? So an epilepsy syndrome is a very characteristic feature of a typical age, typical type of a seizure, a typical EEG finding with a typical prognosis. Okay, so this is a yellow slide. You should remember it. An epilepsy syndrome is something which has a very definitive age group, very definitive type of a seizure, a classical EEG finding, and a classical prognosis. Okay, one of the very good example that we know is Rolandic epilepsy or childhood Rolandic epilepsy or benign Rolandic epilepsy. The age group is 4 to 14. The child would have a nocturnal oromotor twitching around the mouth. The EEG will always show centrotemporal spikes and it has good prognosis and it remits by 15 years. Okay. So from the history, if you are able to identify this particular seizure, you need not to over investigate the child because you know over investigation is just waste of money. You won't get any yield. Okay. So some example, important epilepsy syndrome, every medical student, okay, at the basic level should know are these 6 epilepsy syndromes: Rolandic epilepsy syndrome, childhood absence epilepsy syndrome, juvenile myoclonic epilepsy syndrome, West syndrome, Lennox-Gastaut syndrome, and Ohtahara syndrome. So an epilepsy syndrome can be benign and easily controllable, or an epilepsy syndrome can be intractable and difficult to control. Okay. So this is Rolandic epilepsy syndrome. We saw this video. I'm not changing the video. This is this focal oromotor jerks with focal seizures here in the hands. Okay. Getting generalized subsequently. So 4 to 14 years, nocturnal oromotor seizures. In the EEG shows bilateral typical centrotemporal spikes. The prognosis is mostly good, but some of them can have learning issues. Again, I'm not changing the video for you to realize again. This is the childhood absence epilepsy syndrome, 4 to 10 years, typical multiple absences, okay, 50 to 100 episodes also in a day with a typical 3 hertz. What do you mean by 3 hertz? These two lines is 1 hertz or 1 seconds, and you can see 3 spikes within 1 hertz. So this is your 3 hertz spike and wave complexes. The prognosis is good. This child had this myoclonic or juvenile myoclonic epilepsy. The age is between 10 to 19 years. In the early morning, they have this sudden myoclonus and they can have this GTCS. If you do a EEG, you get this fast polyspikes. If you count here 1, 2, 3, 4, 5, 6. Okay, so there is a polyspikes in the EEG, okay, with the preserved background. The treatment is difficult. They need multiple anti-epileptics. Okay, so this is your juvenile myoclonic epilepsy, and they need medications for a long time. And this is your typical West syndrome, which is an intractable epilepsy syndrome. Starts between 3 months to 10 months. You can have sudden flexion or extensor spasms. If you do a EEG, you have a very chaotic background, okay, very large amplitude spikes and waves, and the prognosis is very, very bad. So every student should try to recognize at least these 4 or 5 epilepsy syndromes, okay. So what are the causes for an epilepsy? So as I told you, there are like 5 to 6 causes for an epilepsy. In next 10 minutes, we'll be able to finish the presentation, okay. So it's important to focus why there is epileptic seizures, okay. Though overall, most of these epileptic seizures have no identifiable cause. If you're able to identify a particular cause, then you can offer a more definitive therapy, okay. Maybe you can get a drug which is in US or UK and you can offer the child, okay. Maybe you can go for epilepsy surgeries and so on. So see, these are the examples of 6 categories I told you in the beginning: structural, genetic, infection, metabolic, immune, and unknown. These are some of the examples. So for a structural, you can have conditions like brain tumors and dysplasia, where you can offer epilepsy surgery, okay. For genetic, you can have like sodium channel mutation, where you can offer medications like stiripentol, cannabinoid oil, ketogenic diet. And if it's infection like SSP or HIV, you can offer anti-HIV medications and isopranosin. Okay. Metabolic conditions like pyridoxine epilepsy or biotin epilepsy, very important to identify these epilepsy as well, where they respond beautifully to pyridoxine and biotin, okay. And if it's like an immune, after an immune, like an autoimmune encephalitis, you can go for immunotherapy like IVIG, steroids, and rituximab, and so and so, okay. I'm not going to the full details, just giving an idea that it is important to look for the underlying 6 etiologies for all epilepsies, okay. So it is also important in the last to go for the relevant impairment in the behavior and the education. You should ask how this epilepsy is affecting the children, okay? Because 1/3 of the children, their life is affected after the epilepsy. They can have hyperactivity. Some of them can have autism, okay? Some of them can have poor learning. Some of them can have learning disabilities. So it's always a teamwork. You should involve the psychologist, developmental pediatrician, geneticist, metabolic physician, okay? The psychiatrist and so on, so that you want to improve the quality of their lives. Most of these children will have sleep disturbances. You should try to control their sleep. You should try to control their behavior, okay? The school, you should always ask about the school, okay? So never forget the how the epilepsy affects the child, okay? And you should involve the geneticist also if you need for prognosticating these children, okay? So now this is in brief about the describe, where you describe the event. You look for non-epileptic events, you look for the cause, okay? And you look for the relevant comorbidities. So let us use the describe for our first case. This was an 11-year-old boy who had 5 episodes of giddiness followed by loss of consciousness. The child was standing. So I'm putting the key words in the history. He felt uneasiness. He had blurring of vision. He became stiff. He was jerking. He woke up, but there was a quick recovery. You know, there is similar nature. So now by this time, all of you would have understood after so much of explanation what this child had. So if I put this describe here for the child, the D pre-ictal, it starts with standing. Okay, this child had non-motor feeling of dizziness. Ictal event, he falls down with loss of consciousness, okay? But there is a very quick recovery in the post-ictal phase, okay? There is no autonomic features. There is no like sustained eye up rolling of eyeballs or twisting postures, okay? So does it look epileptic? It looks more non-epileptic event to me because it always has a trigger and it is always stereotypical with quick recovery. So the seizure type does not apply because there was only 1 episode with brief jerks, okay? The syndrome type does not apply for this child because this is not an epilepsy syndrome. What is the cause? It is mostly a vasovagal syncope or a cardiac syncope So we did a tilt table test and this child is having a orthostatic hypotension. So this is a post-convulsive skin syncope he had, okay. So despite going to 3 neurologists with the 3 EEGs, okay, and 1 or 2 anti-epileptics, he's not having a neurological cause for his loss of consciousness and giddiness. So it's very, very important to look for non-epileptic cause as well. So there is no relevant behavior or education impairment in this child, okay. So the final summary slide is what I told you in epilepsy as a nutshell. So in a nutshell, in a child with abnormal movement, after good history taking, try to understand whether it's a focal event, okay, focal motor event or focal non-motor event, generalized motor event or non-motor event, okay, take a good history and try to classify the epilepsy. You may need, of course, EEG at this point to classify the epilepsy into a focal epilepsy or the generalized epilepsy. This would help you to choose the right drug, okay. And if it's an epilepsy syndrome, okay, you have to be able to identify epilepsy syndromes in the beginning, at least the common ones like Rolandic epilepsy, absence epilepsy, and juvenile myoclonic epilepsy. And then you should always search for the 6 etiologies, okay. So if you are able to do it with a describe acronym, there is less chance of wrong diagnosis or misdiagnosis, okay. So with this, I conclude my session. I'm sorry for taking it long. I think it went up to 1 hour and 10 minutes. So if there are questions, we can take it. Yes. Right. So you can have questions either in the chat box or yes, in the chat box. It's a very basic presentation. I did not want to go into the details of too much details. I don't know. These are the bare minimum basics that that would help you. Right. No questions in the chat box. I'm surprised. So which means I'm absolutely clear. Right. So there is one question. So yes. Dr. Taufik asked one question. So how do you differentiate a tonic seizure attack with impaired awareness and acute dystonia attacks? Okay, right. So dystonia is also a stiffening attack. Dystonia is a twisting posture with a stiffening attack. And acute dystonia is usually secondary to drugs like metoclopramide, or it's a withdrawal syndrome. Okay, it's usually a tardive phenomena. It's usually a drug attack phenomena. The background history would give a fair clue that the child is not lost the sensorium, is fairly regained the sensorium. Sometimes if there are confusion, we have to wait for the attacks. One thing I always believe is that epileptic seizure would always recur. Okay? Even if you don't diagnose it in the first attack, you can always diagnose it in the second attack or the third attack. That is the nature of epilepsy. The nature of epilepsy is to have recurrent attacks. Okay. Whereas a non-epileptic attacks, acute dystonia, if it was a single attack secondary to drug, it usually never recurs. But if you have like sustained twisting postures, twisting is a nature of dystonia and it occurs recurrently in a different setting. You can think about working up for dystonia like Wilson's or other causes. Okay, but I think it is otherwise fairly easy. The background can give an idea about differentiating between a tonic seizure attack and acute dystonia attack. One brief jerk is not enough to categorize as motor. As I told you, even after a syncope, you can have jerks, myoclonic jerks, okay? Multifocal myoclonic jerks. They are motor events, of course, but you cannot call it as a seizure, okay? You cannot call it as an epileptic seizure. Should we see the case of epileptic with one brief jerk? No, you cannot call it as epileptic event with one brief jerk. The scenario is important, okay? How it started, how it ended, what happened in the post-ictal phase. Of course, there are some confusions. In certain confusion, we have to rely with the EEG to know whether the child is having interictal EEG discharges. It does happen in some cases where we are not sure whether it is a syncope or it's an epileptic event. We need the help of EEG to understand whether the child is having epileptic seizures. Yeah. Yes. So in the absence of EEG, like many hospital, which anticonvulsant medication is reasonable to start? That's a very good question. As I told you, the EEG is useful to diagnose epilepsy syndrome. I can repeat again. EEG has there are two important uses of EEG. The first use is that you can predict the risk of recurrence. Okay, if the EEG is abnormal, you can almost confidently tell the child will have another attack. Okay, the attack frequency would definitely be on the higher side. The recurrence would be on the higher side. The other important use of EEG is that EEG can diagnose epilepsy syndromes like Rolandic epilepsy, myoclonic epilepsy, West syndrome, Lennox-Gastaut syndrome. These are the two important uses of EEG. Okay, so like if you are in a periphery, okay, if you are in a periphery or a healthcare center, and you have a child with epilepsy, if you are reasonably able to understand the epilepsy syndrome from the history itself, okay, you can go forward and start a broadline anti-epileptic spectrum. Okay, that is the idea. We usually suggest start with sodium valproate or start with phenobarbital if you're not sure about the type of the seizure. Okay, so this broadline anti-epileptics would help in covering both generalized seizures and focal seizures. So you can definitely start anti-epileptic even without an EEG. Okay, especially if you had 2 or more than 2 attacks, you can start anti-epileptics even before you do an EEG. It's not like that you have to do the EEG and then only you should start an anti-epileptic. It all depends upon what comes to your mind. If you are sure from the history, it looks like a focal seizure, okay, always one side affected with aura, automatism, and aversion. You start with carbamazepine itself.
How do you?
Yeah, so can we diagnose Rolandic epilepsy in the absence of evidence on EEG? That is a normal EEG. See, Rolandic epilepsy, EEG changes are seen in sleep. Okay, so if you get the characteristic story of Rolandic epilepsy, but you did a EEG and if the EEG was normal, especially if it was an awake EEG, the next thing I would do is a sleep EEG, and I will try to do a prolonged sleep EEG like for 3 hours or 6 hours. Okay, so sometimes Rolandic epilepsy will be absolutely normal in the awake state. So this is the importance of correlating with the awake state EEG or the sleep state EEG. I did not go into these details of awake EEG and sleep EEGs, but Rolandic epilepsies, preferably you have to do a sleep EEG. And if you do a prolonged sleep EEG, there is more chance that you can pick up epileptiform discharges. If the prolonged sleep EEG is absolutely normal, then I would doubt the diagnosis of Rolandic epilepsy. I would think it could be something else. The opinion of starting, this is a good question from Dr. Taufik. What is the opinion of starting carbamazepine as an anti-epileptic? Carbamazepine definitely can be started if you're absolutely sure it's a focal event, okay? You need not wait for the EEG, especially like if you know the child is turning the neck, looking one side, staring, chewing, okay? You have, there are interesting scenarios. The child comes and the child would be on something, say Keppra or something, not responding, okay? But even if it's like very clear episodes as far as the history, okay, if you again I say epilepsy is a clinical diagnosis. Epilepsy is a clinical diagnosis. So if you're clinically very sure with your history taking, and if you have seen some or 1 or 2 events from the mobile videos, okay, even without the EEG, you can start carbamazepine for a focal epilepsy. It is absolutely justified. Okay. Dr. Jason has asked a question which is as usual very I mean, a little bit of controversial and tough question. How do you suspect and confirm seizures in an autistic child, and what drugs are preferred? Seizures in an autistic child. So at the outset, I will tell the students and to my colleagues who are here, the concept of epileptic discharges in an autistic child, when to start anti-epileptic medication in an autistic child, and what is the correlation between epileptiform discharges and autism. What is the correlation between epilepsy and autism? These are all million-dollar questions. These are like very controversial subjects, and they require like a lot of in-depth understanding of the child's condition, okay, on a case-to-case basis. Okay, there are epilepsies which can make a child autistic, like a Dravet syndrome, like Landau-Kleffner syndrome. Okay, and there are many conditions in an autistic child where the EEG will be abnormal, but does not mean the child has epilepsy. So this is a bit of a controversial topic. I will leave it open. But if I doubt the child is having epilepsy and this epilepsy is leading to autism, I would treat aggressively. Like if it's Landau-Kleffner syndrome, I will go for steroids, clobazam, IVIG, and so on. If it's like Dravet syndrome, you can go for IVIG, ketogenic diet, so and so on. So if you think this epilepsy is caused autism, then you should treat aggressively. That is my personal opinion, you can say. But no, not even 2 neurologists would agree on the same. It's a bit of a controversial topic. Okay, there are neurologists who would aggressively put antiepileptics to every child with autism, and there are neurologists who would never put antiepileptics to a child with autism unless he thinks about epilepsy. And I'm of the second category. Okay, but it's controversial topic. Yes. So, any questions from the students? Right. So, if there are
No, sir. Yeah.
no, yeah, was the topic clear? I think so. I don't know.
Yes, sir. It was clear, sir. Yeah.
Okay, fine. If there are no more questions, yeah, that's one more questions. In autonomic disturbances, how valid is the argument of deep sight focus? Okay. So autonomic seizures can start from insular area, or it can start from much more deeper areas of the brain, like orbitofrontal cortex or much deeper. And sometimes in autonomic disturbances, it's very difficult to capture those events with EEG, both interictal events and ictal events. Okay. So these sort of disturbances where a child has recurrent paroxysmal events, where there is tachycardia, bradycardia, salivation, cyanosis, okay, you need to revise your diagnosis. You need to think whether these are non-epileptic events, okay. You can try treating the autonomic disturbances with the drugs used for autonomic dysfunctions like clonidine, gabapentin, propranolol, beta blocker, and so on. And if there is no conclusion, we are justified in starting an anti-epileptic along with managing the autonomic dysfunction. So it is very difficult. Sometimes we need a stereo EEG, on-table EEG to go into deeper sites and put needles to find out, to pick up the electrical disturbances. So this is again a borderland zone or a gray zone. Like you can have some children with, especially newborns with apneic seizures and some cyanosis and tachycardia, and EEGs would be normal, okay? We could never pick up the EEG disturbances, especially in newborns. So we treat them like focal seizures, or we treat them like seizures, neonatal seizures, pending other investigations, because it's very difficult to pinpoint an abnormal EEG in such children. But there is possibility that you can find out the focus if you go for advanced investigations like stereotactic EEG or operative EEGs and so on. So. Yeah, if there are no more questions, I'll just wait for like maybe 1 more minute. Sorry for the break. I had to take a call from ICU. Right. If there are no more questions, thank you all. Dr. Alina, can I stop the session?
Yes, sir. Thank you so much, sir.
Thank you so much.
Thank
Thank you so much
you,
for your time.
sir.
Thank you, sir.
Thank you.
Thank you, sir.